Patients who come to us for cosmetic fat transfer as a primary procedure have never, considered implants, don't really care for an implant, maybe the maintenance of an implant and all the problems associated with the implant. The variables in regards to what we can accomplish for them have a lot to do with the thickness to their natural breast tissue, as well as the kind of the density and what we call the compliance to the tissue. I make an analogy towards a sponge. When we have a thin sponge, it'll soak up a small amount, but something that's a little bit thicker will soak up a little bit more. Something that's considerably thicker can soak up considerably more. Also, a sponge that's very hard and firm doesn't soak up quite as much as a sponge that's soft. So we can liken the tissues in their thickness and their compliance and their density to this type of situation. And then we'll maximize what we do for you, but you can't overload the tissue. A critical part to getting the cells to survive is to put that new cell in contact with the cell that's already there. If you do that, the cells that are there give it the helping hand it needs to establish itself and become permanent. But if you overload it, you'll have a bunch of cells sitting there which aren't in contact with cells that are already there, and they're not really going to make it. When the tissue is almost non-existent in the primary and the skin is really tight and thin, we may recommend to the patient they try and find an expansion device. Expansion device, the Brava, unfortunately, the system is no longer available, but some patients still seem to be able to find a system. The Nugalberry is another one. But what that is accomplishing primarily is to stretch the skin out a little bit to improve a little bit of the compliance, help things out mechanically. It really doesn't increase tissue thickness, but it's a situation, as I said, we don't often have to recommend it, but there are occasions when we do. And that's really what we're looking at. And I've done a lot of patients with and without the Brava system, without the Nugalberry system. We get pretty comparable results, so it's not something that's an absolute necessity. When it comes to approaching patients who have had explant, like so many of our patients have, we moved away from doing fat transfer at the time of explant. I was doing explant and fat transfer at one time as the same procedure. But I found that predictability and consistency really dropped off. And we would have absolutely fabulous results in some patients. In patients, we were looking at situations where that predictability and consistency really hadn't been performed very well. We could be looking at one breast that had done well and the other breast had not done very well. And unfortunately, this is exactly the things I see when patients come to us for secondaries too. So I know that it's a situation in my mind. It's kind of universal, and it goes back to what I tell patients, that it's important that the cells that are there extend a helping hand to the new cell. Well, if you've gone through an explant process and or a lift at the same time, you're asking the cells that are there to heal themselves. And you may be asking them to help out a new cell. That's where I think predictability and consistency fall off dramatically. And unfortunately, we see a lot of patients who may have undergone a fat cell transfer concomitantly at the time of their explant and or lift, and they don't have much in regards to what they've been able to retain, but they're quite thin. And so you burn a lot of cells in this process, cells you can't get back. And so that puts us in a much tighter situation of a solid situation. So philosophy-wise, that's kind of where I've moved to. I've moved to addressing it, as I said, at a situation that I feel is more predictable and consistent after somebody has had their explant and or lift. This allows me to do the harvesting of the cells and allows me to maximize what I'm asking of the cells that exist there and the scar tissue that's going to occur regardless. When we're doing secondary procedures on explant patients, it becomes even more difficult if we don't have a cell population to tap into. The same things occur for an explant patient that occur in the thought process in regards to tissue thickness. Unfortunately, for some of the patients, they had very little to start with. And when you have an explant, some of the natural tissue may get sacrificed, especially when you do the en bloc procedure, you're trying to remove it as a whole. That leaves us with 0 or 1 millimeter of thickness of tissue between the skin and the muscle fascia. That's extremely difficult to deal with. We can't do much except to try and establish another few millimeters, place some cells in there, get a few millimeters of foundation established. Then we can build on that. So that's why I tell patients who have had explants that it may take more than one procedure to get them where they want to be. In addition to just, having very little, if any, tissue thickness or the tissues being thin, we're going to be dealing with scar tissue. Scar tissue is difficult in that it can obstruct, it can retract, it can tether, especially as we're trying to expand. It has a hardness and a firmness and a very little of its own natural blood supply. It's just a little, it's a little more scarce in the blood supply and its ability to share. But the only way you're going to change the character of this is to weave new cells between it. And I'll break up scar tissue and expand it and mesh it, but I'll only take it to a certain point. If you are overly aggressive, you'll create holes and spaces where cells will sit, not be in contact with cells that are already there. They're not going to make it. So this is the fence we walk, and the fence that we walk nearly every day in trying to reestablish somebody's breast mount and produce something that's really aesthetically pleasing. So when it comes to secondaries, for the primary patient, patients are often very happy and satisfied with what we've been able to accomplish for them, even in a single setting. But their goals were more to begin with. So those limitations, they're going to go back and build on the foundation. When it comes to the explant patient, again, we're dealt certain cards. The thinness to the tissues and scar tissues are the primary factors. It's very difficult to predict, and I can tell you, I honestly, even after a decade and thousands of cases, I can't predict what's going on underneath that skin. So we do the very best we can to maximize what we do for them in a single session and see where we're at that 3-month point and whether there's going to be any need for a secondary procedure.
That's good.